Hello, everyone. My name is Gabrielle Altit, and I'm a neonatologist at Differential Children's Hospital. And today I will be presenting on the Blue Baby evaluation and immediate management. So my disclosure is that Medtronic, via peer-reviewed competitive grant process, provided monitors and sensor for a research project ongoing at the MCH. We will review today the differential diagnosis of cyanosis in newborn. We'll elaborate the key findings on history, physical exam, and pertinent investigation that will refine the diagnostic approach. And we'll elaborate a comprehensive immediate management plan when evaluating a cyanotic newborn. The first case of Julia, you're called to the delivery room for an urgency section for fetal decel. She's 40-week female, and at birth, she's not vigorous, so you decide not to do a delayed cord clamping. She's brought to the warmer and is blue, apneic, with pre-ductal saturation below targets and a heart rate that is low. So you start resuscitation with PPV and increase FiO2 appropriately so from 21 to 100% very quickly. And despite this, the baby remains with a very low saturation at 55% pre-ductally and a low heart rate. The baby gets intubated at 4 minutes of life. And after that, there's CO2 detector change, the heart rate response, and she has good air entry bilaterally. Despite this, your saturation is quite low with the FiO2 of 100%, so she's brought to your nursery. In the nursery, the pre and post saturations are different. The saturation post is higher. She has normal blood pressure in the forelimbs. Her cord pH is normal, and her capillary pH is not so bad, 722 and CO2 in the 50s. You do an X-ray and you don't find that there's marked RDS. The tube is being pulled a bit, but there's no big issues that you can find on the X-ray. So why could this baby appear low and desaturated? Well, first of all, let's think about oxygen transporting content. So typically in the body, our oxygen transport mainly occurs because we attach oxygen molecules to hemoglobin. And hemoglobin transport oxygen, you get oxygen extraction in your organs, and eventually your venous compartment get desaturated, typically in the 75%. So the majority of the oxygen transport occurs via hemoglobin transport, and a small quantity gets dissolved into the arterial blood. We call this the PaO2. So in a normal heart configuration, the right ventricle is the pump that will pump to your lungs, provide the oxygenated blood to the lungs. The lungs will be filled with oxygen, will do the work of capturing the oxygen onto this hemoglobin, and eventually you get a lot of oxygenated blood flow to your left atrium via your pulmonary veins, and eventually your LV will pump into the aorta and provide all the organs with this oxygenated blood. So the pulmonary vein saturation actually reflects what is happening at the level of your lungs. If the lungs have issues, oxygenated blood, well, your PaO2 hill will be low. So what is cyanosis? It is this bluish tinge or hue of the skin and mucosa, and it's typically mostly appreciated at the level where the skin is very thin. So lips and mouth and earlobes and fingernails, and it's observed clinically when you have more than 30 grams per liter of reduced hemoglobin in your capillary bed. So let's think about cyanosis in three categories: peripheral, acrocyanosis, and central. The peripheral is a situation where you have increased tissue oxygen extraction, and because of this, the hemoglobin on the venous part of your capillary bed is very desaturated. Typically in that situation, the systemic arterial oxygen is normally saturated. Acrocyanosis is very common in healthy newborns. It's a type of peripheral cyanosis. There is increased oxygen extraction because of peripheral vasoconstriction, and typically it occurs at the level of the mouth and the extremities. And what's very common for peripheral and acrocyanosis is that babies will have this very pink membranes because your arterial component is normally saturated. And finally, the one we'll focus today is central cyanosis. So it's really reduced arterial oxygen content and can occur in the first 5 to 10 minutes of life, as we know, as a normal part of transition. But if it's persistent beyond that, it is abnormal and should be evaluated and promptly treated. So why could we have desaturated hemoglobin enter the systemic compartment? Well, one of the reasons could be because the lungs are not doing the work that they're supposed to do. So the blue blood goes to the lung, and the lung is not providing oxygen, with blood coming back to the heart deoxygenated. So think about parenchymal disease, such as RDS, atelectasis, pneumonia. You can think about airway issues. So you have a blockage in the airway, and air is not able to fill the alveoli with oxygen, so plug, malacia, stenosis. You can think because the lungs are actually not being triggered. So CNS anomalies, hypotonia, neuromuscular disorder, or central nervous system issues like HIE, meningitis, apnea, or diaphragmatic issue like if you have a plexus with a phrenic nerve injury. And sometimes you have a mixed picture where you can have a bit of lung disease or airway disease and CNS disease. So you can think about meconium aspiration syndrome. And there are certain diseases with diffusion impairment. So at the alveolar level, the alveoli is filled with fluid or blood, and because of that, oxygen is not able to get into that capillary. The end result of all this is that the blue blood comes back to the systemic compartment and is desaturated. One of the second rare diseases that can cause desaturated blood or blue blood to stay blue is because the hemoglobin is abnormal and is not able to capture the oxygen. So we think often about methemoglobinemia, especially in the context of an intoxication to inhaled nitric oxide, but you can be genetically, have genetic anomalies that leads to methemoglobinemia, and there are other rare hemoglobin variants that can alter the hemoglobin oxygen affinity. The third category of etiologies that we will focus on today is when blue blood enters the systemic circulation by an intracardiac or extracardiac communication. So the end result is that you get these systemic venous blood that is desaturated or deoxygenated blood that will bypass the alveoli in the lung and enters the systemic compartment without being oxygenated. So if you have this situation, you have to think about congenital heart disease. The reasons could be because you get shunting at the ductal level, at the atrial level, mixing at multiple levels, including the ventricular level. And really, you could also have a situation where blue blood never reaches the lung because it keeps on recirculating into the systemic compartment. If you do get blue blood entering your systemic circulation at the atrial level, this will profoundly decrease your pre-ductal saturation. And if you have blue blood entering at the ductal level, this is a typical context where you get pre- and post-ductal differences of saturation. So what are these cardiac conditions that we have to keep in mind when we see a baby with central cyanosis not responding, for example, oxygen? And we will explore some of these diseases a bit more in detail. So think about detransposition of great arteries, either conventional or associated with your double outlet right ventricle. And in this context, the ductus is essential to promote left atrial filling and mixing. You can have a situation where your pulmonary blood flow is ductal dependent. So think about a situation where you have a right ventricular outflow tract obstruction and blood is not able to reach your lungs because it's blocked. So the typical situation is a pulmonary atresia or pulmonary stenosis, but there are variants where you have tetralogy of Fallot or double outlet right ventricle with TOF type, where they have RVOT obstruction and not enough blood flow goes to the lung. There are also situations with tricuspid atresia or Epstein anomaly, where there's a pulmonary valve atresia or functional atresia or stenosis. And because of that, you need your ductus to send blood flow to the lungs so that blood gets oxygenated and provide oxygen to the rest of the body. One other cardiac reason why you can be blue is because your blood that contains oxygen actually mixes with the blood that does not contain oxygen, and everything kind of mixes in one cavity. So one typical lesion that is in this context is total anomalous pulmonary venous return, where all the blood coming back from the lung full of oxygen reaches your right atrium, which usually receives all the blood coming back from the system. And so because of that, you get your oxygenated and deoxygenated blood, and they're all mixing into your right atrium, and baby looks blue. And in this particular context, the PDA may actually worsen or help the situation, and it really depends, and we will discuss this. You have truncus arteriosus, where you have a common arterial trunk and common vessel coming out of the heart, where all the blood will actually mix, and eventually it will distribute differentially between the lung and the systemic compartment. And in this context, PDA will be needed if there is an interrupted aorta or there is a coarctation to provide blood flow to the system. And finally, you can have a single ventricular physiology where all the blood mixes at the ventricular level. And the PDA is most often needed because you either need it to provide blood flow to the systemic compartment or the pulmonary compartment. So examples could be hypoplastic left heart syndrome, double in the left ventricle, tricuspid atresia, pulmonary atresia and tech-septum, and there are various different diagnoses that can lead to single ventricular physiology. So when you suspect a cardiac case, in the majority of time, you will need your PDA. And so if you are in doubt, start PGE, because it will be extremely rare that you will cause any harm while in the community until confirmation of diagnosis. The only caveat is this total anomalous pulmonary venous return. And it is controversial because yes, it can cause harm if, for example, you increase the pulmonary blood flow, but there's an obstructive end. But actually, it can also benefit some of these babies if the pulmonary blood flow goes back through the ductus venosus, which is the one becoming obstructed. So if you have a lung transport, it also is, in certain cases, considered to give PGE for these babies. And TAPVR is extremely rare. So at the end of the day, if you have a blue baby and you think of a cardiac disease, you start PGE, you talk to your referral team, and you make sure that this baby gets an open ductus. The one part that I want to talk before going on is when you have differential cyanosis, but that your preductal and postductal limb are different, with a preductal being more saturated than your postductal. This can be a situation where you have PPHN, and we'll talk about it later, but it could be a cause of, for example, interrupted aortic arch or critical coarctation. In this situation, pink blood coming back from the lungs enters the LV, goes into your aorta, and is normally saturated in the preductal limb. But because you have an interrupted aortic arch or a very severe coarctation, your ductus is quite essential for the postductal perfusion and blood flow. But this blood is coming back from the pulmonary artery, which is actually deoxygenated. So you get normal saturation in the pre, abnormal saturation in the post, but on top of it, clinical clues include low blood pressure in the lower limbs, hypoperfusion of the lower limbs, poor renal output, and very abnormal femoral pulses or absent femoral pulses. So these patients, they need their ductus because they need that to perfuse their organs. So let's go back to Julia. She's a non-responder to oxygen, and this should be a clue to the etiology that it's possibly a cardiac disease. As you know, these babies can be profoundly hypoxemic, and despite that, not show much work of breathing. And the X-ray doesn't look so bad. They don't have that much, tugging or retractions. And some of these babies, you can be fooled because if they become very acidotic due to hypoperfusion, they may become tachypneic by compensatory mechanisms. So we used to talk about the hyperoxia test. This test is you give 100% oxygen for 10 minutes, and you do a pre and post radial sampling of the artery blood sampling, and you measure the partial arterial oxygen content. And this is rarely done nowadays, but theoretically, babies with heart disease will not respond to oxygen, and their PaO2 will not increase, while those with pulmonary disease will respond and there's more oxygen, and so your PaO2 will be high after this test. The babies with PPHN or high pulmonary pressure are kind of an in-between. They may respond a bit to oxygen, but will often stay cyanotic. And the reason they respond to the oxygen is because oxygen is a pulmonary vasodilator. And there are tables available out there to guide based on the response. But in situation where now we have the pulse oximetry, if the baby does not respond to oxygen and you stay profoundly desaturated in a situation where there's no marked lung disease on X-ray or even clinically, you have to think of a cardiac etiology. You should be transferred to a referral center where cardiology will be able to confirm the diagnosis with an echocardiography. So here, Julia, in this particular case, has a pre and postductal differential saturation, but here the postductal saturation is higher. This means that actually pinker blood is entering the descending aorta and goes towards the distal limb, while the preductal saturation is contained of blue blood into the ascending aorta. So what could occur? Well, you can think, okay, could it be the transducer? Do I need to troubleshoot? Is my limb perfused? Do I have a clot or tourniquet? Do I have limb ischemia? Or do I have a congenital heart defect? And really the congenital heart defect that causes this presentation is a detransposition of great artery into a scenario where you do have a ductus and you have higher pulmonary pressure than systemic pressure, which means that the pink blood in the pulmonary artery enters the systemic circulation into the descending aorta. The other situation is a transposition of great artery where there is this interrupted aortic arch or coarctation, and through the ductus, you get pink blood feeding that descending aorta. So let's go back to TGA. Transposition of great artery, the DTGA, is the most common cyanotic heart disease presenting in the first week of life. And this is why I wanted to start with this case. And these babies, as you can see, they get an aorta that is attached to their right ventricle. So the blue blood stays into the blue systemic circulation and they will never reach the lung, while the pink blood keeps on recirculating through the lungs. And so the classical X-ray is this egg on a string, which we did not see in our case, but little caveat. And why is this missed still? Well, this is a 4-chamber view in a normal fetus. RV, LV, RA, and it actually looks exactly the same in a DTGA. And so unless you actually do other views during the fetal ultrasound, you may miss it. And typically in a normal configuration, the two great vessels will cross each other, while in a DTGA, they will typically be parallel to each other. And it's really by doing these extra 3-vessel views that you're able to capture some of the babies with DTGA. And that's why it's still one of the most missed prenatal diagnosis. So think about a DTGA here where you get your blood coming back from your lung, oxygenated, entering your left ventricle, going to the pulmonary artery and kind of recirculating like this. The only way you can send blood with oxygen into your systemic circulation is via this area in between the atriums. Here, oxygenated blood enters your right atrium, enters your right ventricle, and then eventually your ascending aorta in order to feed your organs. Typically, aortic pressure is higher than your pulmonary pressure, so blood flow through the PDA will increase pulmonary blood flow, will increase left atrial flow, and hopefully will favorize this shunt from the LA to the RA. But really, the PDA doesn't help with your mixing. And in this context, you can see that the saturation that you're starting here with is going to be the same here, the same here, and the same here, because the pink blood does not enter, in any case, your systemic circulation via the ductus. Now, in a situation where you have higher pulmonary pressure, or you have an interrupted or coarctation, what happens is that suddenly your descending aortic pressure is much lower than your pulmonary arterial pressure. And so the pink blood is able to enter your systemic circulation via the ductus, giving you this reverse differential saturation. Babies in that situation with higher PVR than SVR will eventually drop their PVR and eventually will have pulmonary arterial pressure that are lower than their descending aortic pressure. And at that point, they will not get mixing at their PDA level, and they will be fully dependent on their atrial shunt. So when you think about transposition of great arteries in the DTGA format, you get these two circulations that are actually not communicating between each other. They're in parallel. You get hypoxic, and eventually you can become into severe metabolic acidosis. So the initial management, if you're in the community, is that if there is a restrictive septum, these babies will be profoundly or could be profoundly desaturated. And it is an emergency. You need to bring this baby under the hand of someone capable of enlarging this interatrial shunt, ASAP. And so in the meantime, you can buy time by starting PGE. This will allow to keep the ductus open, will promote left atrial filling, and will promote this atrial shunting so that there is some oxygen reaching the systemic compartment. And usually right after birth, you don't need high dose PGE. Typically 0.02 mics per kilo per minute will be sufficient to keep your ductus open. Very different from the baby coming much later in life with the need to reopen a ductus. And at that point, you need to start at a higher dose, like 0.05, 0.1 mics per kilo per minute, and sometimes even higher than that. And at higher dose, you risk apnea. These babies may need some stabilization of their airway and respiratory status, especially if they become apneic, especially if they're blue and acidotic, so you might need to intubate. Some babies which are more around the 65, 75, 85% of saturation could be relatively stable and may just need non-invasive support. But in many cases where you have a very profound hypoxia, your baby will require intubation prior to transport. This baby should get an intravenous line and start D10 at maintenance level. And you should organize to be seen as soon as possible to get a balloon atrial septostomy. While waiting for transport, you want to monitor for your vital sign, keep the baby NPO, send some initial workup. Sometimes you don't have the diagnosis, so you want to make sure maybe there's not an underlying sepsis. You might want to have a CBC, make sure you're not anemic, send your gas, your lactate level, your electrolytes, and your glucose level. Some of these babies may eventually need inotropic support, especially if they had acidosis and hypoperfusion and coronary hypoxia, which can lead to ventricular dysfunction. Eventually, they get to a center that is capable to do a balloon atrial septostomy. This is an example here. And locally, we talk about a golden hour. We want to time it from the time of diagnosis or the time of birth to actually achieving efficient mixing at the atrial level. And so if known prenatally, these babies need to be born in a center that can offer this advanced cardiac care. And so we need to have a very rapid sequence of postnatal stabilization, and every player needs to be in place. So locally, we actually developed a septostomy protocol with a multidisciplinary involvement with NICU, neonatologists, and NPs, cardiology, RN, RT, radiology, in order to make sure we achieve the most efficient timing from the moment of birth to actual mixing. And we call this the golden hour. We've done multiple simulations in order to go through the different scenarios in order to achieve the perfect sequence of event so that we can achieve appropriate mixing at the atrial level. And we produced also pre-printed orders for our nurses to be efficient with RTs and medical teams. We also provided and created a pamphlet for the community, both in French and English, so that the transport team is able to provide this to the parents when they take a baby with cyanosis, because if you remember, this is the most common cyanotic heart lesion in the first week of life. And if they need septostomy, often cardiology will need to call them very quickly and obtain the consent very quickly. And so you don't want to have any time wasted, and having these kinds of information pamphlet may help the parents prepare about the information they're about to get. The second case is Julien, which was born at 35 weeks in the monodi twins, Apgar 999, was vigorous with no resuscitation. He was admitted to the nursery because the weight was 1.9 kilo, was kept on room air, but was found to have saturation between 80 to 83%, both in the pre and post ductal limb. You auscultate the patient and found a hollow systolic murmur. The baby's in no distress. The heart rate is normal, has normal precordium and normal pulses, and the X-ray looks within normal limit. You call your referring center, in this case, the McGill Children's Hospital, and we recommend to start PG at 0.02, and on arrival, the saturation 94%. This is the patient echo, and what we see here is the RV outflow tract and the pulmonary valve, which we see quite doming. And when you look at the blood flow, there's acceleration, and this redness is actually the ductus providing blood flow to the pulmonary artery. So this is a diagnosis of critical pulmonary stenosis. In the context of critical pulmonary stenosis, what happens is that the RV is facing a very, very high afterload. And because of that, the RV is not able to pump much blood flow into the pulmonary artery. Blood will flow back to the right atrium, which will be under higher pressure and will pop off into the left atrium, in which case you get deoxygenated blood mixing with oxygenated blood into the systemic compartment, giving this desaturation all throughout your ascending and descending aorta. In this case, your ductus is quite important to provide blood flow into your pulmonary circulation because you don't get enough RBCs going into your RV outflow tract into the pulmonary circulation. And the more this ductus will close, and the more profoundly this baby will become desaturated because you get more blood flow pop off from the RA to the LA. So in this case, you get a pulmonary dependent ductal circulation, which can occur actually in different settings in heart configuration. and eventually will lead to different types of neonatal management and prognosis down the line. But in the community, these patients, if they're blue, will need PGE for ductal patency. So on its own, pulmonary valvular stenosis can be mild to severe, and the most critical one is actually pulmonary atresia. And pulmonary atresia can also occur in the context of an intact or non-intact ventricular septum, and these two entities are quite different. And finally, tetralogy of Fallot or DORV-TOF also may have various degrees of RVOT obstruction and can present sometimes in a similar fashion. So when blue, you want to maintain your ductal patency until confirmation of the underlying diagnosis. And you want to consider stabilization of her respiratory status to avoid confounder. So for example, if the baby was quite unstable, we would have probably intubated or provided non-invasive support. But in a baby with absolutely no respiratory distress, normal CO2, maybe this patient can also stay in room air and just on low dose PGE, but you need to engage a discussion with your local expert teams. This case is Maria, which was born from a mother with a rheumatological condition that required biological therapy. But this mother had actually very high arthritic changes and pain during her pregnancy that actually required naproxen therapy. A C-section was done at 34 weeks because the baby was not growing and there was abnormal Doppler profile. She received betamethasone before delivery. Baby was born small for gestational age. PPV was initiated in the delivery room because the baby was hypoxic and apneic, and eventually is brought to the NICU on 100% oxygen with pre and post saturation of 75%, despite 100% oxygen. This baby was put on high frequency oscillation and the CO2 was around 55 with a profoundly low PaO2. This is the X-ray of this patient, and you can see there's not marked RDS, but the fields are quite black. So big expansion of lungs and very black fields. Upon an echo, what you can see here are different views of the atrium. This is the right atrium, this is the left atrium. Blue means going away from the probe, and what you can see is that there's blue blood continuously entering into your systemic circulation. Upon ductal view, this patient doesn't have a ductus. So this is a diagnosis of PPHN. In the context of PPHN, what happens is that you have high pulmonary vascular resistances, and there's disturbed extrauterine transition where these pulmonary vasculature is not relaxing. Because of that, the RV is facing a high afterload. Because of that, the RV fails. Eventually, there's backup into the right atrium, which will send blood flow from the RA to the LA as a pop-off, bringing the oxygenated blood into the left atrium. The other thing is that because there's not a lot of pulmonary blood flow, well, the pulmonary veins are not receiving a lot of blood flow and the LA is underfilled, promoting this shunting, and you get pre-ductal saturation that is very low. But this patient doesn't have the ductus. So the pre-ductal saturation stayed low all along the course of the aorta. And despite the absence of pre and post-ductal differences, this patient is in PPHN. So this is a reminder that in prenatal life, you get very limited amount of RV output going to your pulmonary circulation. And because of that, the pulmonary vasculature will grow normally, but without being over-muscularized. If you get after birth during your normal transition, your PVR will drop quite acutely, but will continue to drop up to 6 weeks of life to reach normal values of the pediatric life, while the systemic vascular resistance will rise because you actually clump your placenta. And so you get rid of a big vascular network that is of low resistance. So the premature closure of the ductus has been reported in patients exposed to maternal NSAIDs. And so in this case, you get more than the 10% and excessive pulmonary blood flow into the pulmonary vascular bed. This leads to pulmonary vascular remodeling, vasoconstriction, and the arterioles become much more muscular. So in the postnatal setting, you don't get this nice drop in the pulmonary vascular resistance. These patients will present with hypoxic rest failure, black lungs, and RV failure. If you do have a ductus, that's when actually these patients may unload their pulmonary pressure into the systemic circulation. And if you start with a low pre-ductal saturation because of the mixing at the atrial level, you may even so more have a profound post-ductal differential. So these babies might have, like, for example, 85% of saturation in pre-ductal, and 70% in the postductal because of the shunting at the ductal level. And just notice that, I just mentioned that interrupted aortic arch and coarctation can present with these pre-postductal saturation differences, but typically the interrupted aortic arch will have quite normal pre-ductal saturation, and they will also show signs of very profound hypoperfusion to the distal limbs. So this is an echo showing the ductus, pulmonary artery to aorta. And in that particular patient, you can see blue flow showing that blood flow is going from the pulmonary artery and bringing the oxygenated blood into the descending aorta. This is an echo showing very dilated RV with the LV that eventually gets completely pancaked and squished by this RV that is suprasystemic in terms of pressure. So what is the management? Well, you want to ensure appropriate ventilation, but avoid hypocapnia because of the cerebral vasoconstriction. These patients require some degree of calmness. So sometimes they need sedation analgesia, but you want to use also non-pharmacological way to avoid reactive increase in PVR. Oxygen should be administered to aim higher saturation in the 90 to 95%, so whatever we aim for babies. But because of the shunt, sometimes there's a threshold at which increasing oxygen does not increase your oxygen saturation. And INO is the only agent that has been studied in RCT for PPHN, but really for the term and near-term newborns. These patients may need inotropic support and hydrocortisone. Some of them may actually need prostaglandin to unload their RV if they have a ductus that is restrictive. So in the case of a premature closure of the ductus, you can give PG, but the ductus will unlikely open. And in some of these babies with PPHN, they may have concomitant stressor and perineal depression, and you have to consider that they may have underlying hypoxic ischemic encephalopathy. And so these patients should be evaluated for candidacy for therapeutic hypothermia. The last case I want to briefly talk about is Caroline. She's 39 weeker, 2.4 kilo, normal code pH. She was well at birth, and at 10 minutes of life, she was found to be hypotonic with superficial breathing. She was started on CPAP. She was eventually transitioned to high flow nasal cannula, and oxygen actually profoundly increased because of desaturation in the 84-85%. When the transport team arrived, the FiO2 was at 100%, and despite that, the baby was still in the low 80s. And sometimes saturation around 92%, but really between 88 and 92%. So the baby was intubated, gave surfactant, transferred to us. And at that time, the FiO2 was 70% with saturation of 94, and there was no differentials of SATs. This was the X-ray on arrival, which was kind of odd. We wondered, well, could it be TTN? Could it be that there's a bit of edema? Is it RDS? But the lung looked nicely expanded. So due to the non-response to surfactant and the pulmonary edema suspicion on X-ray, we actually called cardiology and we said, well, could this be TA-PVR? And so they came, they confirmed that this was an obstructed TA-PVR of infracardiac type. The atrial septal defect was shunting right to left. There was a suprasystemic RV with severe RV dilation, and this baby was operated the same day for repair. So in this context, what's happening is that all the pulmonary venous return fully mixes into the right atrium with the systemic venous return. And so your entire blood becomes desaturated, enters your RV, your PA goes back to your lungs. And to get blood flow into your left atrium, you have an obligatory shunt from your RA to your LA, eventually going to your LV and feeding your aorta. The big problem with this disease is if this conduit that's bringing back the pulmonary venous return gets obstructed. And this often happens in infradiaphragmatic type of TA-PVR because it goes to the ductus venosus, which eventually closes. If it closes, what happens is that the pulmonary venous drainage is impaired, it's blocked, and so you get pulmonary edema because the lungs cannot drain, and you get post-capillary pulmonary hypertension, and eventually RV failure, and this is actually a surgical emergency. Because there's full mixing and obligatory right to left shunt, these babies will never saturate at 100% despite 100% oxygen. And this is another case actually that presented a bit later in life, and you can see how there's actually very significant pulmonary edema. So in conclusion, the blue baby differential diagnosis includes pulmonary and cardiac conditions, but they're clinically discernible. Non-response to oxygen likely indicates an extrapulmonary right to left shunting. physical examination may allow to differentiate between these entities. And when you consider an underlying cardiac condition, management in the community is key and should include prostaglandin, stabilization of the risk airway with possible intubation or non-invasive support. And you should be calling your teams of the referral center from neonatology and cardiology because time is of essence for many of these conditions, such as transposition of great arteries, which is the most common diagnosis in the first week of life, so cyanotic heart defect, and they may need urgent balloon atrial septostomy, or TAPVR, which may need an urgent surgical correction. So thank you so much for your attention. You'll find here a QR code that will bring you to the website of the NeoCardio Lab, or you can download the NeoCardio Lab app. You can follow me on Twitter at CardioNeo, and on the app, you will find many of the solutions, physiology, and echocardiography that could be of help for educational opportunities. Thank you for your attention, and I wish you a great conference day.